at least, so I think you can start your presentation.
Okay, so everybody can hear me.
Yeah.
Okay, and you can see my screen.
Yeah, we can.
Okay, good. So I'm Alex Nedelcoviciu. First name is Radu, but I go by Alex. And then Dr. Michos, she's now one of our trauma fellows. A year or so ago, we took care of this patient at the hospital where Jefferson sends its surgeons to cover trauma. So Leah was a chief resident at that time. And Leah and Dr. Wong, we made this a video, and this was presented as a video case presentation at the American College of Surgeons last year in October on the trauma sessions. So I'm gonna dive right into the case. Basically, this is what we heard: trauma called stat to interventional radiology. I always tell the residents and the fellows, especially when they first start, is you need to know a few things in the hospital where you're at, like, because you never know where you're going to be called in for all kinds of weird things. So know your you know your cardiac cath lab, know where your interventional radiology is. MRI is also another place where can be dangerous. In the missed format, I'm gonna just go over this slide, and then I'll just turn over the presentation to Leah, Dr. Michos. So this was basically when we got there, sort of the mechanism. So 83-year-old male had portal vein thrombosis. He was undergoing percutaneous thrombolysis in interventional radiology. He was hypotensive in the IR suite. He had abdominal distension. He received thrombolytics, and he was fully anticoagulated. He was unresponsive. He was hypertensive, like undetectable blood pressure really, and hypoxic. And they placed the IV access, and blood product was ordered. You can see on the right side of the screen a circle, basically where there's a small puncture wound in the right upper quadrant, where they access the liver percutaneously to do the thrombolysis. All right, Leah.
Okay. So like Dr. Nedelcoviciu said, this was an 83-year-old male. He had portal vein thrombosis. He was undergoing IR thrombolysis. You can see here he had lack of portal vein flow, minimal flow in the portal vein of the left lobe as well. So he was undergoing chemical and mechanical portal vein thrombectomy in the IR suite under conscious sedation. They also used some local anesthetic. They did a percutaneous transhepatic approach under ultrasound guidance and used a penumbra catheter and gave 8,000 units of heparin bolus as well as 5 milligrams of TPA. Next slide.
Can you see?
Yeah. So he had, as you can see now, flow in his right, left, and main portal vein. The penumbra catheter was removed. Still had a vascular sheath in place, was 12 French in that right upper quadrant. But then it subsequently got dislodged. And like we said, his O2 saturation dropped to the 70s. He had an undetectable blood pressure. A rapid was called overhead, as well as trauma stat to IR. So again, emergent intubation was performed by anesthesia. MTP was activated. His systolic blood pressures at the time were in the 70s. Notably, his hemoglobin did come back at 4.4. And we could see on exam this right upper quadrant percutaneous access site where the 12 French sheath had become dislodged. His abdomen was very distended. TXA and protamine were given at the time as well. This is a fast that we did in the IR suite. You can see blood in the right upper quadrant. And this was the access that was placed.
It was very coagulopathic still, and just oozing, and abdominal distension was getting bigger as we were looking at him.
So what would you do at your hospital? Would you stay in the IR suite? Would you go to the operating room? Would you place a Reboa catheter or other options? If anyone wants to chime in.
That's great. So these kinds of nightmare, they are the best people to manage these cases are Dr. Untracht and Dr. Kasim. So I'm starting with Dr. Untracht. So what are your thoughts on this case, Dr. Untracht?
Yes. So that, first of all, that catheter on the right, that access catheter, that's not the original access. Is that like a groin sheath?
Oh, the one that we showed in, no, that was the access we got later on. Yeah.
Later on, through where? Through the right groin, left groin?
Yeah, that's the groin. Correct.
Oh, okay. Well, anyway,
When we got there, Dr. Ontract, when
Yeah.
we got to the IR suite, they already put a triple lumen in the left groin and under ultrasound, and the penumbra catheter to do the thrombolysis was basically going percutaneously through the right upper quadrant. That circle, that hole
Yeah.
over there, that was
Yeah.
where they put the catheter through the skin, soft tissue, muscle, liver parenchyma.
Yeah. So, and it looks like, if I understand correctly, they put the introducer and the guide wire looks like it's in the portal vein, but somehow the introducer has perforated the portal vein and is not in position. That's the problem, right? Yeah. So, to answer your question, it's too late to stay in the radiology suite because they removed that introducer.
Right.
And they lost it. They went berserk. I mean, they gotta, the first thing to do, I was taught years ago, and I think, over the last 40 years, this hasn't changed. The first principle in bleeding, in vascular injury, is proximal control, not proximal control in the patient, proximal control in the doctor. So they lost the proximal control. Really.
Yeah.
They should have called you first, and maybe they should, do what they do in the old days when they started to do the angioplasty of the heart. They had the open heart surgery team ready to operate on the patient ahead of time. They should have said, no, don't pull it out, pull it back, and I try to advance it back into the vein. Then they could have stopped the bleeding. In the radiology suite, it's too late for that now.
Right.
And the patient's hypotensive. I wouldn't place a Reboa in this case because the problem is it won't stop the bleeding. So you'll stop the perfusion. Eventually the bleeding will slow down, but it's not going to stop the venous bleeding from the, so this isn't the time for Reboa. Although if you do have access, well, you don't have access to the arterial system, the groin. But anyway, I would go to the OR, but you need to call for blood. You got to replace a lot of blood in this poor old man. And so I, got a massive transfusion protocol. They gave, luck is good, they gave him the TXA to reverse the TPA that they gave him, but now they have this very high flow in the portal vein. So, maybe they haven't made this mistake enough. Hopefully next time they do this, don't rip the thing out, pull it back, advance it, put a stent in. Nobody has to know about it. Now the whole world knows about it. Two hospitals. So I would transfuse them, go to the OR. That's going to be the quickest way to rather than trying to, now their hands are shaking. They can't get another catheter in, they want you to take the patient away from them.
Yes.
Yes. I'm sure that's what you did.
Yeah, that's excellent. Dr. Kasim, are you hearing us? Would you like to comment on this case?
Can you hear me now?
Yeah, we can.
Oh, good. Well, I take it this is an iatrogenic injury. Am I right?
Correct.
It is iatrogenic. Okay. And so in a case like this, if I was Leah, and I would be really scared, number one, because it looks like that this is a very, very serious problem. And, you not only have caused the damage, but you're in a duck soup because you are having difficulty stopping the bleed.
Hmm.
So when somebody is bleeding, as a surgeon, I think I would like to stop the bleed first. So playing in the interventional radiology suite is a very bad move, in my opinion. I would go to the operating room. Riboa would be an absolute no-no, in my opinion. Thank you.
Thank you.
That's great. Thank you, Dr. Kassim. So Dr. Leah, I think you can move on as well.
Okay. All right, so we did go to the operating room. We did an X-lap. We evacuated about 2.5 liters of hemoperitoneum, and began by packing off the right upper quadrant and performing a Pringle maneuver as well. Anesthesia continued their MTP. We were able to wean down pressors. His blood, vital signs all stabilized at that point.
Dr. Leah, can I stop you for a second?
Yeah.
It's a piece of paper, how to
I
clean
just
it.
saw that Dr. Varum is also in the meeting. Dr. Varum is an anesthesiologist. So, Dr. Varum, would you like to comment on this case, on how like special tips and tricks that we might need to be aware of while treating this patient in the OR with the anesthesiology team?
Well, basically, this is similar to any other trauma cases in which you're having exsanguination. So I get that it would be very similar management from the standpoint of resuscitation. You're trying to do damage control at the same time. You're trying to maintain perfusion. And they did everything correct. They gave him some TXA and they did massive transfusion. Basically, good communication with the surgeon, make sure that until the point that the bleeding has been under control. Obviously, surgical control will be number one.
Mm-hmm.
And Dr. Varon, are there any specifics regarding the Pringle maneuver when you stop the blood from coming to the liver? Are there any specifics in terms of the anesthesiology?
Certainly, death can occur at that moment. So when you do the Pringle maneuver, you're going to have a massive decrease in venous return. And also, once you release it, you're going to have their, acidosis, lactic acidosis, and reperfusion with furthering hypotension. So you just have to be prepared to have adequate volume. So when you release it, you will be able to perfuse appropriately. But yes, it's like when you're doing a liver transplant, it would be the same principles would apply when you release from the Pringle maneuver.
Great, thanks. Dr. Leah?
Thank you. So what we found, there wasn't any bleeding after we removed the packing, and actually when we released the Pringle maneuver, there was no active bleeding. We mobilized the falciform ligament further and found this 2-centimeter puncture wound in the falciform ligament. Actually, you can see it right here at this blue arrow. So we continued to explore and found this 2-centimeter anterior liver laceration or tract in segment 4 that had fresh clot and was slowly oozing. And, we reversed our coagulopathy at this point, but had to remember ideally post-operatively, we would need to start anticoagulation to prevent recurrent portal vein thrombosis. So what is your next step in management here for the audience? And, how do you explore and repair the portal vein? Would you pack the liver and go back to IR? Would you keep the abdomen open, pack, and take a second look? Or how would you go from here?
Great questions. Dr. Kassim, do you want to start this one? Dr. Kassim, we can hear you.
Okay.
Now.
Since you are observing blood coming out of the hole in the liver, I would assume underneath that hole something is bleeding. So first attempt I would do would be, I probably will inject some thrombotic material into that tract to see if I can stop the bleed. I think I would give it a couple of tries or maybe times 3. And if it doesn't work, then I have to go to plan B and plan C. Plan B was going to be tracheotomy, which will be much more difficult. And plan C is going to be hepatotomy, and that is even more difficult in a patient like this. So I'm hoping that my plan A would be successful and I would call it quit at that time. And I would also get help from the liver surgeon if he's available and ask him his opinion as well. This is a difficult case. I think you need to be alert and kind of on the ball and get as much help as possible from people who deal with this on a regular basis. Thank you.
Thank you.
That's great. Dr. Untracht.
Yeah, so it looks like that the bleeding is relatively under control, but the issue is, how's the patient doing? So are they caught up with the blood pressure, with the volume replacement? Because 83 years old, he could have suffered an MI as a result of the hypotension and now be in heart failure. So, you know, what you would do would depend on the condition of the patient. If he's back to normal blood pressure, no evidence that he suffered an MI, if he's looking good and is no longer not coagulopathic, not hypothermic, then I would take a quick look at the portal vein. So, you know, retract the liver cephalad, do a cochlearized duodenum, and then look at the injury and to get an idea that if, you know, looks like an injury that will take a long time to repair, I would consider putting a shunt in place for the reasons that Dr. Verone mentioned, just to allow the venous return from the small bowel to flow and to avoid edema. It might be a situation where you can easily repair the vein. You might be able to do a thrombectomy and then repair the vein and, you know, solve all of his problems at once. But it depends on the condition of the patient, what you do. If it looks like he's hypotensive or suffered an MI, then I would just pack and, as Dr. Kassem said, go back to the ICU, optimize his treatment. But even if you do that, it would still be better if you had a shunt in the portal vein with definitive control. So you don't have to worry about the recurrent bleeding, and you know that the portal flow is maintained while you're resuscitating the patient.
That's great. A lot of options. Dr. Leah, you may continue.
Okay. Next slide. Okay, so we continued to explore and we, you know, looked at the posterior aspect of segment 4 and didn't see any bleeding, no hole there. We also wanted to make sure there was no injury to the pylorus or D1 as well, and there was not. And at this point, the patient was stable, you know, anesthesia had caught up. And so we began actually by introducing a 5 French sheath into the tract, about 4 to 5 centimeters deep, more superficial than the initial 12 French. And we're able to coil embolize the tract and then also gel foam the tract as well. And you can see that here. Yep. So that's us putting in a smaller sheath into the tract, not as deep. First did coil embolization, like I said, followed by gel foamed of the tract as well. And that's finished product. All right, so this was our fluoroscopy that we shot in the OR. You can see the coil in the liver tract, blue arrow, and then we did a falciform ligament patch as well, which you can see here in this video.
Dr. Leah, may I interrupt you for a second?
Yes.
So Dr. Hampton is asking in the chat, did you do this under fluoroscopy to ensure you did not embolize, causing a gel foam PE?
Dr. Nedelcoviciu,
No.
we
No, we
didn't.
did not do
We
this
just
on the
shot it at the
fluoroscopy.
end. Yeah.
Yeah, we shot that at the end, but you can certainly do that. And I can talk about it when I go over the equipment we use. And I apologize for not being able to look at the chat text because I'm sharing and then I'll just mess up this. But thank you for, I will go over that and why we didn't use the active fluoro because of the information we had with regards to how deep we should go into the parenchyma to be away from major structures when I review the equipment and how we did it.
Perfect. Dr. Untracht, you have your hand raised.
Yes, a related question. So are you sure that you were that the introducer was actually going through the original track and not a false passage or a separate track? How do you did you pass a guide wire easily through the track to be sure you were in and follow that, or how can you be sure that you went the same place as the interventional radiologist?
Okay, so yeah, what I'm gonna do, I'm gonna switch to the equipment and
Yeah,
I'm gonna
go for it.
explain this, and that would, and then you go over the rest.
Yep. Sounds good.
Okay, so this is the video that we presented. So first of all, when we got sort of things under control, I called for a second surgeon. I did not start messing with the liver until I had an extra set of hands. This is the video that we submitted and we presented American College of Congress last year in October. Basically, the equipment that I used was, so you have to understand, I went to work and I assumed call and I did not think that this is what I'm going to end up dealing with. And especially, I don't walk around with 5 French sheets in my pocket or Surgifoam or you know Nestor embolization coils. So you don't need necessarily a sheet that is as big as the hole that was created. You know, I grabbed the 5 French. There was definitely imaging available beforehand with kind of the depth, like how thick is the liver parenchyma, with regards to how far should I put the 5 French sheet in, and then you could see when you were looking inside, and it was going in easily without any resistance or you know, I did not feel like I'm creating a false track. And then I used a nested coil embolization. Now in IR they use Amplatz or plug, which is sort of a similar device to plug it, but you know, we grab the coil. And then Surgifoam, because you want to do first the coil, then you do the gel foam, so you prevent that gel foam flying into any kind of circulation where you don't want it. You can see, like, this is my daughter who helped me with the pictures yesterday, but you pull out this wire that basically prevents the coil from the Nestor coil embolization device to go in and out as you're getting ready to deploy it. The 5 French sheet now is with the blue introducer in, so I did have the blue introducer in, not just the French sheet, because the hollow bore can catch onto something. And I did not want that. This basically sort of U-shaped metal is what was pulled out of the Nestor coil embolization device. And this straightens out, and you use this to push the coil that is resting here inside. Okay, so once I had this position where I wanted into the liver, I put the Nestor coil embolization device into the sheath, and then you see we're using the wire that was holding it in place, and you can see on the left side of the screen, my index finger, how the coil is coming out. It's designed as such that it has this little fuzzy, I guess, material attached to it that basically catches on and is thrombogenic and creates basically the, stopping the bleeding, staying in place and not going anywhere. And you can see the same floor shot I showed before. So let's go over, some of the pitfalls here. So what if we would have had, so to answer the question, avoiding this coil embolization basically to go via hepatic vein into the IVC, into the lung. So I thought that if I would have had ongoing venous bleed significant with the Pringle maneuver on, I'm dealing with an SVC. It wasn't, I'm sorry, a major hepatic vein bleeder. So that can be problematic when you deploy this. How do you go around it? How do you translate this into the trauma patient, let's say, who comes with an isolated puncture wound like that? So one thing you could do is you can get a J-wire, just a simple J-wire where you try to salvage an A-line or to salvage a central line. And you pass that wire, and then you see if it's going freely beyond, 4 or 5 centimeters where we had the established kind of depth through of the liver parenchyma from the prior imaging. If it's stopping, okay, fine, it's not going into the vein. If you're worried, you can do an active fluoro shot with a J-wire, okay? You will feel the same thing you don't want to feel when you put a central line, that the wire is not passing. So in that case, okay, fine. If I deploy the coil here, I'm good. To be extra safe, you can do active fluoro shot. We did not do that because we felt like we're at the right position, and then we did that first. And after that, we used the gel foam, which basically we ripped in pieces in a little cup, put some sterile saline over it, and then became this slurry that was suctioned through a syringe and then just pushed through after. So coil first, and then the gel foam. Now, what if we'd have had concomitant arterial bleeding with the Pringle on? So you have to first rule out your replaced or accessory hepatic arteries to make sure you are actually, controlling them appropriately in the location where they are. And then, depending on how much bleeding and oozing you have, you could either pack, have IR. Ideally, if we were in a hybrid room, so have IR come and access the femoral vein and just gel foam embolize empirically, which should have been in the left hepatic artery because it was in the left lobe. Or if that's not possible, then you could, expose the left hepatic artery and maybe consider ligating it. You're not tying off everything. You still have perfusion to the liver. You have the right side circulation. So those were the things that kind of, crossed my mind, as I was doing this, and for the future, how am I going to go about making sure this doesn't go into the IVC, into the lung. So I hope this answers some of the questions. I'm going to give this back to Leah now.
All right. So post-operatively, he did well. We did, close his fascia. We placed a JP drain in the right upper quadrant. He was brought to the SICU post-operatively, extubated on post-op day 1. His hemoglobin remained stable. It was very important that we restarted anticoagulation, and we felt good about doing that on day 2. He was transferred to the floor on post-op day 3. We removed the JP on day 7, and he was discharged to rehab on day 14. And 1 year later, still doing well, and was off Eliquis at the time as well. So now we'll get in. There was this actually paper or video presentation done at East in 2019, just discussing injuries to the portal triad. So portal triad injuries are rare, an incidence of about 0.21% of trauma patients, but they are difficult to manage with a high mortality rate, 50% if one structure is injured, and 80% if multiple structures are injured. Isolated portal vein or hepatic artery injuries result in mortality rates of 60 to 70%. Isolated extrahepatic bile duct injuries are more favorable with survival rates of 70% and mortality usually due to other intra-abdominal injuries. So they, recommendations for management of portal triad injuries are based on small single institutional studies and expert opinion. So first, just to review some anatomy, our portal triad, our portal vein, as we all know, is posterior in the portal triad and gives us about 80% of blood supply to the liver. Our SMV and splenic veins are posterior to the neck of the pancreas. Her hepatic artery is anterior medially, and as we know, hepatic arteries can have anatomical variants. Our extrahepatic bile duct or common bile duct is anterolaterally. We have our common hepatic duct, cystic duct, and common bile duct, and this blood supply courses at the 3 and 9 o'clock positions. So, stepwise approach to hemorrhage control in these injuries. First, of course, packing and or compression of the liver in the right upper quadrant. Then you want to go to your Pringle maneuver. And once your bleeding is controlled, kind of take a step back, good communication with your anesthesiologist and your team. Make sure you have enough blood in the room before you start diving in to repair these injuries or further explore these injuries. Always consider your adjuncts like your angiographic embolization, your endoscopy, your percutaneous options. These are interventions that may be available either in the immediate period or in a delayed fashion. Make sure you have good exposure and start with your exposure. For extrahepatic portal triad injuries can occur anywhere from the porta hepatis to the posterior pancreas. You want to do a Coker maneuver is often required for these, especially for exposure of the duodenum, the head of the pancreas, the IVC, and the retropancreatic portal vein and common bile duct. Peritoneum surrounding the hepatoduodenal ligament can be opened and carefully dissected to inspect the portal triad structures. So starting with our portal vein, it's the most likely source of exsanguinating hemorrhage in the portal triad injuries. Majority occur in the mid portion of the hepatoduodenal ligament, and exposure can be difficult, especially if there's exsanguinating hemorrhage. If necessary, you may need to divide the bile duct with delayed reconstruction of that to aid in your exposure. Just to note about stab wounds, they're usually clean lacerations that are amenable to primary repair. You want to debride. Of course, perform a tension-free repair with 5-O-proline preferred. And just, when you tie that final knot, maybe with a little slack to allow the vein to fill appropriately and not narrow and get that hourglass appearance. You want to rapidly restore portal flow like we were discussing earlier to the liver and allow for delayed reconstruction. This may be with shunt placement. You may want to use like a small caliber chest tube or with and secure with stace sutures. And when placing the shunt, do not debride the vein. You want to preserve the length for definitive repair later on. You're just trying to restore that blood flow. In hemodynamically unstable patients, you may need to ligate the portal vein. Survival is about 60% if performed early, but obviously can result in devastating bowel ischemia as well. So this is just showing, again, our common bile duct anterolaterally, our portal vein posteriorly, and our hepatic artery anterior medially. And then this picture over here is with a shunt in the portal vein. So hepatic artery injuries, it's infrequently injured, but difficult to isolate, can be amenable to primary repair. Again, initial steps, vascular control, always debride, tension-free 5-O-proline repair. In, profoundly unstable patients where you're not able to get repair, you may need to ligate the hepatic artery. The liver can tolerate this if your portal circulation's intact. Again, it's appropriate in exsanguination, but may result in compromised hepatic physiology in shock states and patients with diminished portal flow states. The biliary system does not receive portal flow, so this can lead to biliary necrosis and biloma. So make sure you perform your cholecystectomy in this instance. Bile duct injuries are most frequently injured after penetrating trauma. 88% occur in the common hepatic duct or common bile duct. Identification can be difficult. They're small, maybe non-dilated. Avoid excessive dissection, so you don't want to devascularize the common bile duct. Remember, your blood supply is on the 3 and 9 o'clock positions. If it's amenable to primary repair, you can do this. You want to, avoid as it will likely stricture. Only if it's an isolated bile duct injury with no segmental loss and they're hemodynamically stable, you would want to use a 5-0 PDS. T-tubes, repairing over T-tubes is preferred. Again, repair over a T-tube with 5-0 PDS in a longitudinal fashion. Don't forget your endoscopic and percutaneous options. And these can always be first managed in a damage control way with packing and drainage, and then subsequently endoscopic or percutaneous procedures. And if you really need to, ligation with delayed reconstruction as well. So definitive management after your damage control procedures and they've been adequately resuscitated in the ICU. With your portal veins, you would remove your temporary shunts, restore vascular continuity with vein graft or PTFE. The IJ approximates the portal vein better than the saphenous. With the bile duct, debridement and creation of your biliary enteric anastomosis, like your hepatico-jejunostomy, brought up in a Roux-en-Y fashion, and an anastomose with 4-0 PDS. You want to use a T-tube or some sort of feeding tube as a stent as well, so as to not stricture stenosis later on. And just post-operative considerations, obviously we want to focus on the sequela of our massive transfusion and our coagulopathy, but you can also get sepsis, surgical site infections, portal vein thrombosis, biliary leaks, liver abscesses, liver necrosis, biomas, and bile duct strictures as well. And I believe that's all we have. We presented this at ACS, like Dr. Nedelcoviciu said. Thank you.
That's great. And
So-
just to make sure that I understood correctly, so you did not have any complications postoperatively, right?
No,
That's
you did
awesome.
very well.
Yeah, that's awesome.
Yeah.
Doctor,
Yeah, we got some luck. But again, do you need to do this on the fluoro? Not really. If I were to do this again, or how can I do it better? I would say I'll get a J-wire or starter, especially if I see some heavy venous bleeding coming out of it, and then just adjust where my sheath is and pull out slowly until I feel like the wire is not passing. If I'm not sure, then I can shoot an X-ray in the OR. You don't necessarily need fluoro, and then you see your wire. Okay, it's in the liver. It's not in the IVC. So thanks for coming out. Any other questions?
excellent. Dr. Untracht, any comments on the case?
Yes. So if I understand correctly, you never really looked at the portal vein that, you did a Pringle maneuver, waited a few minutes, bleeding stopped, and you never exposed the injury in the portal vein, and, you put the gel foam down the track. So are you assuming that, maybe you're not, but it suggests that you thought that all of the bleeding occurred through that tract. That's why the patient got hypotension, because the bleeding was through the tract and not through the portal vein. But if you didn't look at the portal vein, obviously you were right about that. The portal vein wasn't bleeding after a few minutes of Pringle maneuver. It never bled after that. So even if you didn't look at it, you were correct. The bleeding stopped. Now, the second point I would make is that this man at 83 presented with portal vein thrombosis, and they went through all this procedure with the potential complications that he in fact suffered, when they could have just managed it with Eliquis to begin with, was really what happened in this case. A year on Eliquis, and then the vein opened up, the portal vein opened up, the thrombosis. So, two issues that, and the management of the portal vein thrombosis, that's for the interventional radiologist. But in this case, what worked better was just Eliquis. It was effective, and you know, but I assume that the optimal management, the accepted management, is what the radiologist did to try and put the TPA down the vein, or was it? I don't know. You probably looked this
He
up.
had so he had some progression of the clot while he was anticoagulated. I don't remember if it was on Eliquis from the beginning. Maybe he was on Coumadin. But because he had the progression, then they decided to do the thrombolysis. You know, when I had the Pringle on and there was no more venous bleed coming out, okay, then it's not a hepatic vein, that's through the tract bleeding, because they may have gotten through it when they access the portal vein, and the bleeding was coming through the portal vein, through the hole in the portal vein, through the tract of the liver. So to get to that hole in the portal vein, I would have had to split the liver in half, and I'm not sure that that would have been like the actual hole, because it was in the parenchyma. On the where we did the Pringle, there was no bleeding from the portal triad right there per se. It was through the liver tract. So I thought that was the more of a straight shot to get to it and hopefully coil embolize and hope it does well.
Okay, so if I understand correctly, the bleeding was through the left portal vein after the bifurcation in the intrahepatic portion, and if you had examined, if you did a Coker maneuver, whatever, you wouldn't have seen any injury in the
No.
But
in the triad, there wouldn't have been anything in the triad.
But all the blood was intraperitoneal, so then the blood was coming through that tract, flooding the abdomen through there, and then so you think that with the gel foam you got down to where the posterior, so there it was just one tract coming through the liver down to the hole was where you saw the sheath outside the portal vein. That was intrahepatic, all intrahepatic. Yeah. Okay.
I have not seen any other holes around in the liver parenchyma. That's why we looked on the undersurface, just in case, you know, when it got dislodged, if it pushed through something. The depth, again, there was imaging available that, you know, staff in the OR was pulling up, and we kind of measured, you know, what's the depth of the, you know, that lobe through to the portal, to make sure we're not putting the sheet in the portal vein and then not even put something thrombogenic in it, but even coil it, and just, you know, that would be a bigger problem, because the alternative would have been.
So you had all these names on your paper. I assume some of them were the interventional radiologists, because they could have done the same thing that you did without, you know, without going to the OR, right? They were right there.
Yeah, it was I had two chief residents, and I had an extra surgeon, Dr. Coley. He was actually the backup, and he, you know, he was the second person who came in.
Okay,
and,
but the interventional
from
radiologist,
I stole their tools.
okay, but you know, they could have done the same thing, you know, and no one would have known nothing. You know, there you go. No one would have. They would just got bleeding, put the gel foam, whatever. So there you go.
But once you lose access, they lost that access.
Exactly.
Everything broke loose between fully heparinized and thrombolysis. It's mind blowing how much blood you can lose when you're anticoagulated like that through from the portal vein, which is a lot of blood flow. Other points I wanted to make. Actually, one last one, because the other one were made to answering the question. The access. So in the groin, we had that triple lumen, but luckily we also had the peripherals, large bore peripherals in each upper extremity. So that was good, because, you know, normally when you have liver injury, or, you know, you want to make sure you have access above the diaphragm as well. So most of the MTP was going through the upper extremity. Now, in the setting of, he was reversed with protamine and everything he got, but I you know, nobody was feeling very courageous about doing a subclavian in this gentleman. An IJ could have been probably something that could have been done easily in the OR. And I'm sure anesthesia could have done it, but we had upper extremity IV access in case. Just want to make the point about having access above the diaphragm.
Definitely. That's great. Dr. Kassim, any final comments on the case?
Well, beautifully managed by innovation of what is available in a different hospital than the main Jefferson Hospital where Dr. Alex works as a call cover. I have a question for Dr. Alex. If he has ever managed a case where the portal vein was injured behind the pancreas.
I remember a couple of cases like that in the portal triad with the devastating injuries and the not good outcomes. We actually had patient die on the table.
Oh, one other thing. I'm so glad that that you beat Kansas City guys. I can't stand them.
Thank you. Yeah, we're happy too, everybody. That's why I put the pictures.
Thank you.
Nice. All right, guys. Thank you very much for presenting the case, Dr. Alex, Dr. Leah, and thank you, Dr. Untracht, Dr. Kassim, and Dr. Varam for the discussion. I think it was a great case, very interesting options, and I think it's something interesting to look over. Hopefully, we don't get any cases like this. But if any of us get some trouble like this one, we may have additional options to use. So I hope to see you all next week on Monday at the same time. We're going to have another presentation, very interesting as well. And thank you very much for being here today.
Thank
Bye-bye.
you.
Thanks, everyone.